So welcome everyone to the latest in our series of NHR Knowledge Mobilisation webinars. My name is Lindsay Bean and I'm a Senior Research Fellow in Knowledge Mobilisation in the NHR Dissemination and Knowledge Mobilisation team. My co-host today is Jeremy Taylor. Jeremy, would you like to introduce yourself?
Yes, hello. I'm NHR's Director for Public Voice. I have responsibilities for our work on public involvement and also in relation to dissemination and knowledge mobilisation. So both my responsibilities come together in this webinar.
Thank you, Jeremy. So today we're delighted to welcome three speakers who are experts in their field. Professor Krysia Dziedzic is a NHR Senior Investigator and Director of Impact Accelerator Unit at Keele University. The Impact Accelerator Unit has a dedicated patient and public group for knowledge mobilisation and implementation called the Link Group. Working alongside her is Laura Campbell. Laura is a knowledge broker at the Impact Accelerator Unit. She's a former journalist and works with researchers and external stakeholders, including members of the public, to find, adapt and share research knowledge for mobilisation and implementation into practice. Our third presenter is Professor Sophie Staniszewska. Sophie is a Professor of Patient and Public Involvement and Experiences of Care at Warwick University. She is currently Chief Investigator of an NHR-funded study that aims to understand and develop a role for patients and members of the public in the implementation of health and social care evidence into practice. So we're delighted to welcome our speakers to share with you their knowledge and experience. And I'm going to now hand over to Krysia, who's going to start the presentation. Thank you very much.
Thank you very much, Lindsay and Jeremy, for this opportunity for myself, Laura and Sophie to come and to talk to you about mobilising research knowledge with members of the public and perhaps share some of the challenges and opportunities in our journey. Next slide, please. So what we plan to cover in the next session is the importance of mobilising research knowledge with members of the public, to discuss and share some of the practical examples of mobilising research knowledge and perhaps share some of our top tips that we've gleaned along the way. And then to finish off with the evidence about how to involve members of the public, what we know so far, and really highlight next steps. Thank you very much, and I'm thrilled that Laura and Sophie are with me on this journey. So next slide, please. So in a session like this and thinking about mobilising knowledge with the public, it would be most important to actually put the public right at the heart of our presentation. So Jane is one of our public members from the Link Group that you'll hear a little bit more about, and Lindsay's also sort of described, but I think it'd be very important really just to hear what the public view is around working in this space about mobilising knowledge from research for the benefit of patients and public. So let's just hear from Jane.
Hi everyone, I'm Jane and I've been a patient public representative with Keele University for 5 years. When I first became involved in research projects, I quickly realised that I needed to learn a whole new language, together with jargon, terminology, and not to mention the acronyms. To ensure 100% involvement from public members, lay language and plain English has to be used. The word evidence to most people is something to do with the police or a courtroom. Over time, I began to wonder how much of the research carried out actually made it to the public's ears, and when it did, how much of it was actually understood. Patients and public are embedded in research from the very start of any project, but once the project ends, then what? The public rarely read a research paper in a medical journal. So how does this research get into the real world? And how can the public really benefit from all that hard work? Most public members who contribute to research are keen to know what happens next. and given the chance would want to help implement that research into practice. The public needs to be embedded in the implementation of any research and encouraged to help mobilise the knowledge. If the public understand the research findings, they can offer practical and realistic advice on how it can be used to benefit themselves and everyone else in the real world. Surely this is why research is carried out in the first place. Patient and public members are here to help with implementation, so please use us. Thank you and enjoy today's webinar.
Super. Thank you very much, Jane, and thank you for joining the webinar today as well. Much appreciated. Next slide. So we're not going to dwell on definitions of patient and public involvement, knowledge mobilisation, implementation. The NIHR have got some great resources on their website that cover these definitions, and we do have references at the end of the presentation as well. But patient and public involvement in research is something that many of us have been doing for decades, and certainly it's the NIHR that has driven this approach, that it's not done to, but it's done by and with patients and public. Knowledge mobilisation in a very practical sense is taking knowledge and to where it is needed, but it may need to be transformed in a way that is can be then used. So research knowledge might come to a space where patients and public will interpret it. Also health professions may even develop innovations or new models as a result of that knowledge, and it's that transformation then that gives you an innovation to take forward that you can then implement where you may want to change a service or change an approach, and the implementation will be different depending on the context. So something you might do in accident emergency might be very different to what you might do in public health or in a care home. Next slide, please. So just a few thoughts. We're starting with the practical application, and this is possibly because practice is a little ahead of the knowledge in this space, and we are working at pace to try and catch the research evidence and catch it up to where we are in practice. So just a few examples, starting next slide, please. Just a reminder of what was the involved research cycle, where patients and the public are involved in all stages of a research cycle. It's worth noting that as researchers, we start at midnight, and a very large number of us actually go to 6 o'clock at night and then go back to midnight to start the next study. But actually, patients and the public want to go right from midnight through 6 o'clock, right through to midday the following day. So it's our duty of care to work with patients and the public in teams to take them through right the way through to implementing the results and actually seeing and evaluating the results in practice. It's also worth noting that you don't have to wait to the end of the cycle to mobilise knowledge. You have the opportunity at touch points throughout that cycle to mobilise knowledge, and that's something that is really key to research. Next slide, please. So again, we're not going to talk in detail about knowledge mobilisation theory, models and frameworks, and we have references to those. But I've just drawn on one in particular that in practice we found quite powerful. Don't always get it right, but we've certainly been experimenting and using this approach. So this is a community of practice approach. The idea that you bring a diverse group of people together who share a concern, set of problems, are passionate about a topic, and deepen their knowledge and expertise by interacting on an ongoing basis. And the one community of practice that's been incredibly successful for the NIHR is the Race Equality Public Action Group. And through their working together and actually sharing the lived experience and actually sharing expertise has brought us the NIHR framework for public involvement in research, for race equality, race equity and public involvement in research. So it can be immensely powerful if you're working together to co-produce in a very equal setting. Next slide, please. So locally at Keele, and arising from a knowledge mobilisation research fellowship that had been funded by NIHR, we developed a public group to help us with this knowledge mobilisation. So they bring their personal, professional volunteering expertise, they can act as a voice, and they can co-produce things that we can take forward into practice. And with the next slide, I'll just give an example of how powerful the experiences can be. So on the next slide, through the Knowledge Mobilisation Fellowship, there was a focus on joint pain and osteoarthritis. So on the right of this image, these are lots of guidebooks and patient information written and co-produced with patients, starting with the UK, but then going across Europe, and most recently having that work in Africa, in West Africa. But on the left, when we were working with a group of researchers and academics in New Zealand, this is very much how an academic might see osteoarthritis. So it's a very biomedical approach. It's looking at the joints and focus on this. But when they worked and co-produced with public members from the Maori population and Pacific Islanders, this is what they came up with in the middle. So this was the illustration of what it meant, what joint pain meant. And it was about the lived experience and the valued activities that people have in their everyday life that were culturally adapted as well for that context. So, and we also found out that they didn't even have the term osteoarthritis in their language. So it just shows you how patients and public can be really powerful supporters of and transforming knowledge that can be used. Next slide, please. So at this point, I'm going to hand over to Laura, because it's Laura's group, the Link group, and Laura's been coordinating it. And Laura's going to kind of give us some of her learning and her examples that she's taken forward in the several years now working with Link. So thank you very much, Laura. Over to you.
Thank you, Krysia. Next slide, please. Yeah, so we wanted to share with you some real practical examples of public involvement in knowledge mobilisation and the implementation of research. And like Krysia said, at Keele, the Link group have been going for 7 years. So I hope some of what we have to say will be of interest, and also to try and highlight something that we feel really strongly about, and that's the importance of investing time, investing thought, and investing funding into public involvement in knowledge mobilisation, because it really is that pathway to research making meaningful change. So I'm going to give you a couple of examples of PPI involvement in knowledge mobilisation at Keele, which have used that community of practice framework that Krysia spoke about earlier. So this one here, as you may know, the NIHR produces themed reviews which collate recent research evidence. And this one moving forward was a physiotherapy review, which looked at particularly at musculoskeletal well-being, and it featured over 50 research studies within it. And the Link group were part of a community of practice, which was made up of clinicians, commissioners, academics, knowledge mobilisers, and patients and the public. And the group's challenge was to prioritise what research from this review should be implemented into local clinical pathways. And within this community of practice, there was a lot of learning from each other around this. These roundtable discussions that we have were actually really changing minds. GPs and commissioners were thinking differently after hearing from our patient and public members, hearing about their different contexts, their experiences, and also vice versa from patients and the public. And another challenge we had was to create an easy read version, which we did in collaboration with the Chartered Society of Physiotherapy and the NIHR. Because the Link group told us that the review had a lot of information relevant to the public in it, but it was quite long, quite complex. And so they worked with us to condense that big review down to 24 pages, which wasn't easy. I think we had 32 versions by the end of it. But this final co-produced version you can see on the right here has a lot of images. It has studies which our patient and public group prioritised as being important to them. And it was split into 3 easy to understand sections with easier to understand phrasing. So for example, saying like the bottom line, the clinical bottom, the research has shown us that, for example, patients can access physiotherapy directly. So that key message, that key bottom line from the research. And this version coincidentally ended up being the go-to version for the healthcare professionals in the community of practice as well. So that's one example. Next slide, please. So Be Free is an example of creative co-production that we've been working with the Link Group on. Again, the Link Group were part of a wider community of practice, which included clinicians and researchers, all who had the aim of finding ways to support people living with long-term chronic pain with their mental health. And we started with a very small pot of funding from the Health Foundation Q Lab. And really, we started with a blank piece of paper. We didn't know what the resource would be, but together we firstly created a prototype, which enabled us to then access more funding. And then we went on to create this, which is Be Free. And Be Free is an evidence-based, branded, recognisable, hopefully you'll find engaging website, which has on it free training for everybody, a repository of local support information, particularly for Staffordshire, and informative animation. And we also had two main knowledge mobilisation challenges in this piece of work. Firstly, to just consider diversity. When we were thinking about the central character, we would never be able to sort of represent everyone if we'd had a human. So the Link Group chose a bee, which they thought symbolised the hive support and sort of being active and positive and getting moving and supporting yourself. And we had the challenge again of presenting complex evidence. So the Link Groups helped us to think up the Hive 5, which were 5 easy to remember phrases which really summed up the research in this area. And they were get talking, get active, get creative, eat well and sleep well. So good, simple messages that convey this complex knowledge. And then they also, Link Group members, use their networks to promote Be Free and boost its uptake into their patient participation groups and their local hospital resource centres, for example. So not only did they help create the knowledge, they helped to take it out as well. Next slide, please. And so the Link Group also worked with us on a more strategic level too. We were finding that all of our resources we were creating at Keele were in different places. And so they put forward the idea that it would be easier to find all of that knowledge in one place. And so that's where www.keele.health came about. And it's a website with reliable evidence-based health information, training, leaflets, animations, all in one easy to find place, which link out to other resources. And as you can see, there's a patient side, public side, and a healthcare side. And again, they co-produce this website and are trying to spread the word about it within their networks. Next slide, please. So we have a couple of resources that you may find useful. On the left here are top tips for doing knowledge mobilisation written by the Link Group themselves, including things like thinking with a marketing hat on to get research out to the public, working with volunteers and champions to do this, and presenting any information clearly, making it engaging and positive. And on the right hand side are guiding principles for involving members of the public in implementation. And this was a graphic I did for a recent paper that we published in the European Journal of General Practice, which has drawn together all of our practical experience and used practical examples. So for this, we also drew on some qualitative research carried out in the Impact Accelerator Unit by Laura Swades, which included those patient involvement, that public involvement experience in community of practices. So if you look around this graphic, some of the key things, it's important to start out small and invest in relationships for the long term. We really try to get to know our public members and their different experiences and interests. As we know, understanding context is vital for implementation and knowledge mobilisation, and this helps us to identify public champions to take part in projects. It's important to have clear role descriptions, planning ahead for where public involvement will be at its most useful, and co-producing plans, so that might be implementation plans or communication plans, and then carrying that out together. Making sure everyone involved has the same expectations of the project and its outcomes from the start. And that's where then role descriptions also help. Creating welcoming environments, you know, teas, coffees and cakes in person or online, having those reflections and opportunities for catch-ups. Agreeing ways of working collectively. PPIE knowledge mobilisation is rarely done in isolation. We often work with wider teams of clinicians and researchers. Just like in PPI and research, communication needs to be clear and jargon-free. Support meaningful PPIE knowledge mobilisation. So it's not tokenistic, it's involvement of the public on an equal level as everyone else in the project. It's sharing power, it's sharing contribution, reimbursing for time. Providing evaluation so we know what worked and what didn't, and reporting and sharing that PPI experience as well, because we're always looking for ways to improve. So in our experience, then PPI knowledge mobilisation has very much been about public members taking an active role. So being the early adopters of innovations, being public champions, ensuring that end users of research have access to information which can really help to balance power and support decision-making about their care. And the experiences of public contributors in knowledge mobilisation really is multifaceted. It's often wider than the experience of just living with a condition. It's also about life skills, about roles in society or roles in public networks and connections or links. Next slide, please. So finally, I asked the link group what it means to them to be involved in knowledge mobilisation. And this is a little poem from Patricia, which I think sums it up perfectly. She said, straightforward information and practical advice, choosing words and pictures to reflect a healthy life, working closely as a team, a cog within a wheel, creating something special, a resource with appeal. Next slide, please. And I think I'll hand over to Sophie now to talk a little bit about Piper.
Thank you very much, Laura. So my focus is very much on taking the next step. So public involvement in implementation, and that might include taking a piece of guidance or a piece of knowledge and actually changing health and social care practice. And we know that this is important because a lot of research is produced and nothing may happen for quite a long time. And sometimes people talk about a 17-year gap between evidence production and implementation. Next slide, please. So the key question or the key opportunity we can consider is whether public involvement in implementation could be this secret ingredient to closing the implementation gap. So when knowledge is produced, it then becomes readily used by everybody, including health and social care practitioners and patients. And the Piper study is really exploring what this potential looks like. So what could public contributors and patients do in this field of implementation, how it might look, what their roles might be, and also how we might support them. Next slide, please. So what do we know about public involvement in implementation? Because we want to draw on the evidence to inform practice. Krysia and Laura have done a great job of demonstrating the sorts of practice that is out there, which is incredibly valuable, but we also want to draw on this evidence base. So in our Piper study, we've looked at what does this look like? And in the implementation world, there are many theories and frameworks of practice. Very few mention public involvement in any capacity. And in the world of public involvement and the evidence base, there is very little link through to implementation. So they're two very large but important areas of evidence, but very, very few links. And in the Piper review that we are undertaking, the realist review of literature, we found these green shoots. So we're seeing the birth of this new evidence base that links these two really, really important areas together. But at the moment, a lot of the knowledge that guides what we do is very much held in practice, as we've seen today. So the Piper study, really, the key question we are asking is how best can we involve patients, carers, service users, and the public in implementing evidence into practice, and that includes both health and social care evidence. And Piper, very briefly, has 4 work packages. The first is the realist review, where we're gathering these green shoots together. The second is the qualitative phase, where we're starting to reach out and talk to people about their experiences, but also the potential for this area. The third one is a very exciting co-production phase led by Joe Langley at Sheffield Hallam, which will produce Piper as a resource. And the final one will be run by colleagues at Keele with Krysia and Laura piloting Piper. Next slide, please. So what are some of the challenges we have to implementation? So just a few things to run through, and colleagues have already mentioned some aspects of this. So accessing evidence, understanding scientific jargon is a real challenge for us, but incredibly important that we find ways of enabling people to write in clear ways, to have clear messages in their research, things that people can take and use in whatever format they want. Negotiating the research landscape of journals and papers is always a challenge. Even in research, we have information specialists who help us do that. So finding information is not always easy. And then if you find it, you may come across a paywall where you're asked to pay quite a lot of money for that knowledge. So that can be a real problem as well. But also finding reports and guidelines can be really challenging. They're sometimes hidden on professionally focused websites, and they're written in language that's very much directed at professionals. So again, that can be really, really challenging. And I think for me, an important aspect of this is also if we think about the lack of public involvement in writing papers, because I think as soon as you get a public contributor involved in writing, the clarity of the writing often improves in terms of the messages that paper provides for a wider community. And we don't have many journals that have a plain English summary of the paper, or even a plain English summary of the abstract or anything like that. So that can be a real challenge, as well as difficulty interpreting scientific information. So reading a paper and then thinking, how does it apply to me? What can I do with that? Next slide, please. So in terms of opportunities, there are many. In Piper, we're really excited about what is emerging, and I think they include potential roles for patients and public contributors, and they could be passive, and that's not in a negative sense. That's someone who might just want to support an activity, or they might want to partner with a team in the same way as Keele colleagues undertake knowledge mobilisation, or they might want a very sort of active role, really leading some work. And we're seeing that with the work that some patient organisations are doing. And it could be at an individual level. It could be you implementing a piece of evidence in your own care. It could be at an organisational level, working with colleagues at Keele or in other organisations, or it could be at a sort of system level with patient organisations really pushing forward either on implementing evidence or even de-implementing evidence when there is some knowledge about harm that is being caused. Next slide, please. And just a few highlights from our review so far. We've identified the important potential role that patients and public contributors could have in implementation. And many of the public contributors we've spoken to have said to us, it's really important that beyond the research, we have a role in actually making a difference. That's why we've got involved. But organisations need to plan and prepare for public involvement. This is a very new area of activity in relation to implementation. We need to be realistic, and we need to be accepting of failure. Things won't always work, and those are learning points. They're really valuable, and we need to work with them. We also need flexible and responsive ways of working. So if a group of public contributors has an idea about implementation which supersedes what might be happening, then we need to think about how we respond to that. But also practice knowledge is vital and really important. And until the evidence and theory develops, that's our primary source, but it will remain as important as the evidence-based knowledge from research. Practice knowledge is vital in this area. Next slide, please. And just to give you a summary of what Piper will offer us as a community, we hope it will signpost people to roles. So it'll be a navigator. Individuals will be able to understand what the potential looks like. It will give us a quick summary of the literature, and we'll also publish that. Piper will be a toolkit, so it will help us to understand what the potential is, and it will create some guidance on good working environments. We know the context of delivery is really, really key, but we are also keen to nudge internationally. We want to say to our community, actually, this is a really vital area for us to grow internationally as well. And Piper will also provide guiding principles. Okay, next slide, please. And the next slide after that, and I'll hand back to Laura.
Thanks, Sophie. So I'm just going to recap then on what we've covered today. So hopefully you'll have a good idea now about the importance of mobilising research knowledge with members of the public. We also considered some practical examples of mobilising research knowledge with members of the public, and we identified some top tips. And we discussed some of the evidence about how to involve members of the public to mobilise research knowledge, and highlighted next steps as well. Next slide, please. So we know that mobilising research knowledge with members of the public gives community insight and knowledge of contexts into which research can be implemented. Public contributors help to make knowledge engaging, understandable and accessible, and facilitate the implementation of research into practice. Secondly, guiding principles can help you to think through practical examples about working with public members to mobilise knowledge. But remember that every context and every person is different. And finally, recognise that you can involve members of the public in implementation of evidence into practice, but the evidence base is still in its infancy. So hopefully those are the key take-home messages from today's session. Next slide, please. Yep, and we'd like to thank you for listening, and we look forward to some good questions and answers.
Thank you very much, Laura, and also to Krysia and Sophie. And we do have some questions already. Just to recap on how we're going to do this, we've got about 20 minutes left for Q&A. We may not get through all the questions, but we'll do our best. So if people could ask succinct questions, and I will try and direct them to the most suitable panelists and ask for succinct responses. Please put your questions in the Q&A space, not the chat space, please. You can ask anonymously if you don't want to reveal your identity. That's your call. And please, other people do either vote or not, depending on how much you like the question, because that gives us an order of priority. So that's the drill. Without further ado, let's go into and I'm going to take the questions in order of popularity. That's the democracy aspect of this. Bruno has asked a question. How have you been measuring the impact of the co-produced material you've developed? I think that's a question for you, Laura, because it came up while you were presenting. So let me go to you in the first instance.
Yep, and maybe Krysia can help with this as well. But I mean, we do collect, the website metrics, social media metrics, but obviously that doesn't tell the whole impact story. That just gives us some numbers. So we've recently also started to embed feedback into any co-produced resources that we put out there. So we recently, for example, have done an animation explaining in simple terms what osteoarthritis is and what can be done about it. And within that, we wanted to really see if this was what difference this was making, if people were learning from this, if people were finding it useful or not, and how we could improve on that. And so the animation that we put out there, we also included a feedback form within it, which is given us that. So we have the metrics, but we also have the extra information about how is this making an impact? Is it making an impact? Are we doing the right thing? How can we change it? Krysia, did you have anything you wanted to add to that?
No, that was a very eloquent answer. I think what I was also thinking about that maybe it could be like a case study as another way of looking at impact. And we have an impact bucket at Keele, and you think of champagne buckets, so rather than a bucket that you'd wash the car with. But what we try to do is capture these little messages or little indicators that it might be having impact. And the other day we received an email from a physiotherapist who said that they'd used Be Free in a consultation for joint pain with a client who had some, I believe, learning difficulties, and it was actually their parent who contacted to say it's been the most meaningful consultation that they'd had in all the time that they'd had consultations, and the actual Be Free information really reached out and made a difference to this one individual. So you can collect numbers of metrics, but also being able to capture one case study of how perhaps it might have an impact that you might not recognize in large data.
Thank you very much, Krysia. That's a very full response. Let's move on to the next most upvoted question. This is a really good one, I think. How do you ensure you reach the parts other engagement doesn't reach? In other words, underserved communities, so often left out of our this type of engagement. I think that's I might come to you in the first instance, Krysia, and then maybe see who else could add. But I'm also conscious we've got quite a lot of questions, so I won't field out every question to every panelist, otherwise we'll run out of time. Krysia?
Yeah, no, thanks, Jeremy. Well, what a great question. And I think the important thing is, I feel in knowledge mobilisation is the research may not have included underserved communities, but certainly the mobilisation of that knowledge can be undertaken with underserved communities. The NIHR Race Equality Framework for Public Involvement in Research for race equity has been a fantastic initiative to enable us to think about working with underserved communities. We have a race equality ambassador that works in our public involvement team to help us make sure that we're very authentic when we're listening and we're working with populations. We have another group that of multiple disadvantaged individuals, and again we work very closely with them so that we try to understand their needs and work in the ways that they have. And it's worth noting that the NIHR programme development grants for reaching out and working with communities have been really game-changing. And I think that they initially only planned to fund a handful, and they probably burst the budget on over 30 different initiatives. So there's a real appetite with the NIHR in funding the opportunities. So it's just, making those connections and working together to find out what's important.
Thank you, Krysia. Sophie, is there anything you want to add from your perspective?
I guess from my perspective, it really highlights the importance of making sure underserved communities are part of the research that we undertake. So those voices are already there. And I know we're working very hard towards that goal. I guess from our perspective, we are trying to build in diverse voices into the work we're doing in Piper, because we can see the huge potential there is for working with different groups and communities, but also by reaching out through some of the other NIHR initiatives like the health determinants, research collaborations, the HDRCs that are focused on inequality. I think those routes could be really powerful for us in the future in terms of knowledge mobilisation and implementation.
Thank you very much, Sophie and Krysia. Yeah, there's a lot already going on in this space to try and improve the way that research connects with communities that have often been overlooked, but still a long way to go. Let's move on to Lena's question. Lena or Lena, I'm not quite sure if I'm pronouncing it correctly. But, what have been the key barriers or challenges when taking this approach, and how is this usually funded? It's really two questions there. I think, again, Lena's question came up while you were presenting, Laura. So I might come to you in the first instance to ask about how we've overcome barriers and challenges, and what were they?
Oof. That's a hard question.
They're all hard questions, but they're good.
They are good, yes. I think I mean, there are definitely different challenges, and I think each challenge is probably project specific. But if you're thinking about the challenges for PPIE in knowledge mobilisation, they're perhaps similar to the challenges of PPIE in research. I think avoiding that tokenistic tick box PPIE involvement, public involvement, is really important, and we try very hard to create those long-lasting relationships and really bring patients and the public into the group. If they're working with clinicians, research especially, try to create an equal playing field where everybody has the same voice, everyone has the same level that they can speak on, and really just to bring everyone together and try and understand different contexts. I think some of the challenges can sometimes be we're all coming at a problem from completely different directions, completely different experiences. A clinician will have a different experience than a patient or a commissioner, for example, and that's something that we found in many of our community practices, that once we start speaking, once we start to break down those barriers between us all, then we can really start to move forward.
Thank you, Laura. Yeah, and it occurs to me that as you're speaking, having a community of practice is a good mechanism for overcoming challenges and barriers that arise. Yeah. Let me move on, actually, because there's a bit of an inclusivity theme in a number of these questions. So I think we can return to some of these issues in the next question. I might start off with Krysia for this one, but then see if others have got views. A huge barrier to PPIE in both co-production and implementation is trust. So it relates to the earlier question about underserved communities, but it's more specifically about how can we build trust with communities when they often feel that they've been let down by research and by health services. Certainly an issue very much on our radar in my bit of NIHR. Krysia, what is the way to build trust, particularly where it's been lost in the past?
Yes, and I think the race equality framework for public involvement in research is absolutely at the heart of that too. I think, and the way that the REPAG started was actually listening to the communities. So they had multiple consultation events where members of communities were there to facilitate discussions and listened. And I think you really have to truly listen, understand and hear the experiences of the communities. And I think if you then also, if you're then with them on that space and wanting to work together to build that trust, they do reach out the hand to help you. So I think you have to listen, you have to understand their needs, and they will then help you to understand how to move forward. Certainly in our PPI team, 50% now of our PPI team are from the Black, African, Asian, Caribbean heritage communities. Now before, that wasn't the case. So we weren't really in a position to be reaching out and working with diverse communities.
Thank you, Krysia. I don't know if either Sophie or Laura want to add anything to that.
I think just briefly, really, I think as well for knowledge mobilisation, having patient champions is a good way to build trust with communities. For example, some of our link members have actually gone out into their patient groups, for example, or their own community groups, and been a champion for the research that we're sort of doing together, a champion for the information that could help support people, and building those networks themselves. So it's not coming from us directly, it's they've gone on to champion it and create their own networks, relationships, which has then sort of helped to foster that trust between us all.
Thanks, Laura. Sophie?
Just briefly to add, trust has emerged in our realist review as almost the core concept underpinning so much activity, and trust is even more challenging to develop, I think, in an area that's emerging, and there isn't always a clear pathway through it. So the knowledge we have about trust is so important to bring into this space, and our rapport study many years ago that Tricia Wilson led, that published in 2015, identified sort of components of trust in public involvement that can be developed, and included things like reciprocity as well. And that takes us back to making sure the research we do is relevant for communities, so those communities want to stay involved and want to implement and change practice. So it takes us through the whole life cycle, really, and trust and flexibility and welcoming failure, I think, are really important. So you're ready for things not to work so well and have a plan for how you're going to mitigate that, so that there is transparency and honesty. All those elements are really important.
Thank you, Sophie. I really like the idea of reciprocity, because I think sometimes research can feel exploitative. It's all about take, take, take. So what is the research community giving back? I think it's a good question to think about. The next question is a bit more practically focused. Is there a set of criteria in the decision for easy read versus plain English versions of publications? I mean, Laura, is that, how do you go about doing that? What are the criteria? Or is it not for you, this question?
Maybe not for me.
I could pick that up.
Yeah,
Sophie.
thanks, Sophie.
Well, no, I was just going to say that the NIHR guidance on plain English summaries is really excellent, and was developed with Jane Whitehurst, who's a public contributor. And Jane has done some fantastic sessions for us, taking researchers through what is a good plain English version of a publication. But it often is just the summary or the abstract. There is a big question we have here for what do we do with full papers, and how do we take that knowledge and create something different? So I think there are current criteria, and there's some great ones NIHR have produced, but I think we need to think about things in more creative ways in the future too.
I'll give a plug for NIHR Evidence, the website, which includes plain English, plain language summaries of recent NIHR funded research. And we certainly, I ought to know what criteria we use for turning things into plain English. It's not easy, actually. It's quite a skill. And one of the things in our part of NIHR is also to kind of provide guidance and help to researchers on how they can do exactly this. So I ought to know the answer to this question myself more, but it's a very good one, and maybe we can return to that theme. Let's move on to Karen's question. In my experience, there is little, if any, budget for sharing research with the public put into a funding application. How are NIHR going to tackle that? I can say that there have been some recent discussions at the NIHR board about the overall approach to and funding for dissemination and knowledge mobilization, and recognition that we probably haven't been doing enough in that area. How that transmits into actual money and where that money comes from, they're still live questions, but I can absolutely tell you that at the most senior levels of an NIHR, this is an issue that's on people's agenda in terms of the overall resource that goes into dissemination. And that would include how we involve the public. I don't know whether any of the panelists have got anything they want to add to that.
I would add that it would be a very natural extension to projects to have something at the end which moves us beyond dissemination to knowledge mobilization, and also how agencies could perhaps join to think about implementation as well. I mean, if we were able to crack implementation, then the research we produce, if it was going into practice more quickly and more appropriately, would be a winner for everybody, I think. So I really hope we can achieve that.
Yes, me too, Sophie, thank you. The next question is an interesting one. It seems a time-consuming and expensive, and I guess that the whole business is about engaging the members of the public in implementation, knowledge mobilization. So what are the most important things to do first? Yeah, it's a really interesting question. What's the order of priority if you've got limited resources, which we often mostly do? Krysia, have you got a thought on this?
Yes, well, I suppose it comes back to the funding area, because we can embed knowledge mobilization in research funding grants, but we're also we're lucky enough to also have access to other funding that's not research funding. So Health Foundation, we've had funding, charities, we've had funding, the NHS, if we're working in partnership with the NHS, we have funding. So I think that it's important to have dedicated people who are willing to develop the relationships with communities and curate and support those who are coming to the table and being part of that. So, you know, it's an extension. It's just an enhanced patient and public involvement in research. So it's part of the whole picture. And I think that there will be people, and we've got members of the public on the call today, and we've seen them in their chats responding to some of the academic questions. So the public actually giving a hand. So we don't think that we're on our own. We can work together and try and work out some of the challenges on that. And the public do amazing things. They're going the extra mile in giving us the resource as well. So it's not a one-way street. It is definitely a co-produced.
Thanks very much, Krysia. I just note in the chat, Helen Roberts has put a link to some information about Easy Read, and it's particularly useful for people with learning disabilities. Thank you for that, Helen. That's very useful. If we find other resources we can share afterwards, we will do that too. Shahfaz has asked an interesting question. What work is being carried out to ensure the minimizing of duplicate work and forums around PPIE? I can say, as the Director for Public Voice, we have a public partnerships program board that tries to have an overview and a more coordinated approach to doing things in a consistent way so that there isn't duplication. But NIHR itself is such a complicated beast that people are sometimes doing the same things in different areas, and sometimes that's fine if it's very locally based and needs to be, suitable to the local context. But it's an ongoing work to make sure that we don't reinvent the wheel, and also move things on, move on from that, because I think that's probably a question that probably more directed at me than anybody else. Laura has asked a question. Can you share any top tips about accessing using evidence that are also, my screen jumped. Can you share any top tips about accessing and managing resources to involve the public in implementation for those who are new to this? Maybe that's one for you, Laura Campbell, because you have your top tips that come out of the work. If you were new to this, what in particular would you focus on?
Yes, I guess being new to PPIE in general, do you think, or PPIE and knowledge mobilization specifically? If I was new to PPIE and knowledge mobilization specifically, I think it's making sure I'm going to go back to relationships again. I just keep coming back to establishing those connections and those groups and nurturing those long-term relationships from the beginning, and just making plans from the beginning. We spoke about implementation not existing on its own at the end of a research project, and same with looking forward to how to involve patients and the public in knowledge mobilization at the end of the research project. You can also start to think about that early on and start to bring them into the research at the beginning, start to get that investment and that champion role again right through the research cycle from the beginning to the end. That answer the question at all?
Thank you very much, Laura. I think that's a good attempt. Thank you very much. Just got time, if you're very brief, Sophie, to answer the question that's directed at you, you describe challenges to accessing and using evidence that are also felt by many frontline professionals. Improvements for the public could also improve engagement of workforce. Interested in your reflections on this, different universes colliding. Anything you can quickly say in response to that?
I completely agree. It's a really important point. I think we need to get much better at unlocking the knowledge we publish, which is often directed at such a small group of colleagues, but actually thinking really outside of the box of how we communicate this. And I know NIHR and Jeremy and Lindsay are thinking about all these different sorts of issues, but if we can crack that, then it will benefit everybody, won't it? It will be a real democratization of our evidence and knowledge.
Thank you, Sophie. We will have to call it a day there because we're almost out of time. Thank you for all your questions, everybody, and for your votes. Sorry I didn't manage to get through all of them, but we haven't done a bad job in getting through a lot of them. So it remains for me to close this session by making a few points. First of all, thank you hugely to Krysia, Laura and Sophie for your presentations and your engagement in the follow-on discussion. Thank you to my co-host Lindsay and for all the team behind the scenes who've made this webinar possible. Please do fill out the evaluation form. The link will be put in the chat, probably as I'm speaking. It's really useful to have your feedback. This webinar and all our other knowledge mobilization webinars can be found on the NIHR TV YouTube channel. So if you want to have another look or direct somebody else to it who couldn't see, please do so. That's it. Thank you all very much for your participation in today's event, and enjoy the rest of your day.